Now over to the panels. Now we'll go to the panel discussion. The topic today we have chosen is hypertension, comorbidities, prevention and management. Okay, let me ask my first question to my brother Mangesh. Mangesh, what are the common comorbidities in hypertension?
Thank you, sir, for those kind words of introduction. Good morning, everybody, and morning, Siddharth sir, Dr. P.C. Manoria sir, Amit, you as well. And thank you, Dr. Manjula and Shirish, for this opportunity. Now, the commonest comorbidities, as we all know, which can come along with hypertension, apart from diabetes, is usually dyslipidemia, metabolic syndrome, obesity, chronic kidney disease, and some immunocompromising situations like malignancies, and nowadays COVID as well. So these are all the common comorbidities that we commonly encounter. But the most common which we encounter are usually diabetes, dyslipidemia, and obesity and metabolic syndrome.
Okay, thank you, Mangesh. Though we have comorbidities, whatever you said, we'll deviate a little bit because we'll have to ask something on CAD. We must ask something on CKD also because yes, nephrologists and cardiologists are there. First, let me ask our beloved mentor, Siddharth Shah, who has architected the Indian hypertension guidelines. So according to you, what is the target or goal of BP in the case of diabetic hypertension?
Yesterday we had a beautiful talk regarding the goal of blood pressure, and it was agreed that the target goal of blood pressure should be 130/80 for all. But beyond the age of 85, the goal of blood pressure can be 140/90. Otherwise, it has been now agreed by all the nations that the blood pressure goal should be 130/80 millimeters of mercury.
Thank you, sir. P.C. Manoria, sir, coronary artery disease is common in hypertension. Though it's not a comorbidity, it may be a complication. What are the pitfalls in diagnosis of coronary artery disease in patients with hypertension? Because this is a common problem which we come across. I think we should highlight this practical implication. How do you diagnose, what are the pitfalls in diagnosis of CAD in a patient with hypertension?
Good morning, everybody. Now, one of the common problems we face in hypertensive patient is we have history of angina on our part. The stress test is positive when the angiogram is normal. Now, this is very important to remember, and there are several reasons for it. The first reason is hypertension can produce a positive stress test due to increase in demand of the myocardium. The oxygen consumption of myocardium is increased because of increase in blood pressure, because of an inappropriate increase in blood pressure during stress testing, left ventricular hypertrophy. So as we know, angina is an imbalance between demand and supply. But in hypertensive, these are the reasons you can get a normal, you can get a positive test and a normal angiogram. The second reason is there may be associated microvascular disease due to endothelial dysfunction, capillary rarefaction. So you can get a normal angiogram and despite a positive stress test. So how do we make the diagnosis in a simplistic way? While looking at the angiogram, if the dye clears off rapidly and the epicardial artery are not showing any lesion, this means no epicardial disease, no muscular microvascular. If the dye takes 4 or 5 cycles to clear, this is an easy test to suggest there is microvascular disease. Otherwise, if you want to diagnose microvascular disease, you have to calculate CFR, which should be less than 2. In patients who are going for an angioplasty, if there's associated microvascular disease and you don't look for it, the results of angioplasty may not be appropriate and you may have precipitation of angina due to embolization in the microvascular. So this syndrome, when we look at is 17 times you get a false positive stress test in hypertension, and the message is please try to control blood pressure before submitting the patient to stress test. But still you can get a false positive stress.
PC Manoria, as a sub-question, in a microvascular angina, what is the treatment? You said angio is not possible. So what is the treatment you give?
The microvascular angina, usually we can give nicorandil and we can give calcium channel blockers.
Why not nitrates in the microvascular?
Nicorandil has a better action on the microvascular bed compared to nitrates. So
Because-
that's why we prefer Nicorandil when we are talking about microvascular.
Because Nicorandil
Nitrates
is
can
the Nicorandil only can give the it can donate nitric oxide. Nitrates cannot donate nitric oxide in the microvascular arena, and it has got ischemic preconditioning also. Nicorandil will be a good drug in angina. Now I'll go to Dr. Sanjay Maitra. How common is hypertension in CKD? Because CKD can be a cause of hypertension, or it can be effect of hypertension. How common is that in your
Good
practice?
morning
Because
to
you're a
each one
nephrologist.
of you. Good morning to each one of you, Dr. Muruganathan, Dr. Siddharth Shah, Dr. Manoria, and the other senior members of the faculty, and my thanks to the organizers. Answering the question in one word, it's very common. Let's put it like, for example, and it depends on the stage of chronic kidney disease. The worse the renal functions, by the time one reaches kidney disease stage 5 or even not on dialysis, the range or the prevalence of hypertension in that group is to the tune of 90%. By stage 3, in the early parts, I would say that the incidence is around 50 to 60%, and it progressively increases.
Okay, thank you, Sanjay. Amit, type 2 and hypertension. What is the common soil hypothesis? Why type 2 diabetes and hypertension, insulin resistance? What is the common soil hypothesis? Amit, unmute. Please unmute.
So sorry. Good morning to everybody. Dr. Muruganathan sir, Dr. Siddharth Shah sir, Dr. Mangesh Tiwaskar, Dr. Manoria sir, and Dr. Maitra. Pleasure to be here. Thank you so much, Dr. Sasha, for this opportunity. So the common soil hypothesis for many of these conditions today has been put forth. When it comes to type 2 diabetes and hypertension, we've noticed to begin with a lot of insulin resistance coming in. That leads in the long term a lot of beta cell fatigue. That leads to in the long term a lot of insulin deficiency. And to top it up with atherosclerotic risk also increasing with hypertension, all these components have been an overlay of a genetic and an environmental factors. That has been today being considered as common soil hypothesis for both a metabolic condition like type 2 diabetes and a metabolic condition like hypertension.
Thank you, Amit. Mangesh, what is the role of lifestyle changes, especially aerobic exercise? And now we also introduce the resistance also in case of CVA and hypertension.
Yeah, sir, if you really look at the recently published guidelines and even our Indian Hypertension Society guidelines published under the leadership of Dr. Siddharth Shah, the third guidelines that we have published, the most important thing after becoming aware about the hypertension is to implement an adequate lifestyle change. So no matter it may be a DASH diet, no matter it can be a aerobic or anaerobic exercises, weight reduction, smoking cessation, they all have class 1A evidence. So, and sometimes, a properly implemented lifestyle can serve you as probably one or sometimes even two pharmacological medications or the drugs that have been equal to like that and without side effects. And sometimes they can give blood pressure reduction up to 2 digits. So it's very important for us to implement these lifestyle therapeutic changes as a part of hypertension management.
Thank you, Mangesh. Sir, Siddharth sir, what is the ideal antihypertensives in the case of a metabolic syndrome or in a diabetic hypertension?
Thank you, Dr. Muruganathan. I think your pioneer work in the blood pressure must be recognized even in the Hypertension Society of India. You have done a lot of work for home blood pressure monitoring, I remember. So I think a few comments on home blood pressure, though you are the moderator, I thought it fit that you should talk about a little about home blood pressure monitoring whenever the chance permits.
Sir.
But answering your question, the best drug, as everyone has agreed upon, if there are no contraindication, ACE inhibitors and ERBs are the first drug of choice in metabolic syndromes.
Thank
along
you, sir.
with hypertension.
Thank you, sir. Thank you for bringing out that home blood pressure monitor. I'm very happy and overwhelmed. The previous speakers emphasized that home blood pressure should be done in nephrology aspect, in the cardiology aspect, and home blood pressure is the poor man's APBM. So in this conference, I request all of you promote home blood pressure monitoring. Please, request your patients, especially in the lockdown period, in the COVID period, to control hypertension, home blood pressure monitor is very, very helpful. Now, Dr. Manoria, sir, obstructive sleep apnea is not uncommon in patients with hypertension and also in the resistant hypertension. How do you make diagnosis and what are the predictors of SCD in patients with the OSA?
Obstructive sleep apnea is a very common comorbidity, and it predisposes the patient to myocardial infarction, atrial fibrillation, sudden cardiac death, and even a stroke. The diagnosis of obstructive sleep apnea is made by the apnea-hypopnea index. The normal is less than 5, 5 to 15 is mild, 15 to 30 is moderate, and more than 30 is severe. There has also been work on the basis of polysomnography as to which subset of patients of obstructive sleep apnea are more prone for sudden death. And it is seen that if the mean nocturnal oxygen saturation is less than 93% and the lowest oxygen saturation is less than 78%, these are distinct subset of patients of OSA who are at high risk of sudden death.
Okay. What is the drug we use in the sleep apnea hypertension? What is the best drug?
Besides other drugs, the aldosterone antagonists have been found to be useful because they decrease edema in the pharyngeal area. So it is seen that if you use spironolactone, even eplerenone, it decreases edema and improves obstructive sleep apnea. But lifestyle modification, CPAP is a very good treatment that has to be resorted. Without CPAP, you may use antihypertensive drugs, but the hypertension remains resistant in vast majority of patients. So CPAP and aldosterone antagonist is the only drug with decreased edema and is found to be useful. Otherwise, they are poor responders and they have resistant hypertension.
So, good point that spironolactone not only is a diuretic, it also produces a reduce the edema in the upper airways. That is one point favor in spironolactone. Dr. Sanjay Maitra, please briefly tell me what are the pathogenesis or pathophysiology of hypertension in a chronic kidney disease?
Firstly, there are basically four mechanisms. The one which we all know and attribute to is the stimulation of the renin-angiotensin-aldosterone system. That's easy to understand. As the number of glomeruli come down, in the remnant glomeruli, there is ischemia and there is around the pericapillary tubules, there is less of blood supply. This stimulates the renin and subsequently the angiotensin and then finally the aldosterone. The other mechanism is in the part when the sodium retention starts. This is in the later part, and that is one. Sodium and volume retention is the second part. The third is the stimulation of the sympathetic nervous system, which in turn further stimulates and worsens the renin-angiotensin system, and the renin-angiotensin system further stimulates the sympathetic system. And the fourth is the lack of the nitrous oxide, the damage to the microvasculature, and the endothelin. These are the four major mechanisms which have been attributed to the generation of hypertension in the context of chronic kidney disease.
Thank you, Sanjay. Amit, what is the choice of antihypertensives in chronic, cardiac failure?
Right. So most of the patients of chronic heart failure with hypertension, I think a lot of cardiology colleagues will agree that beta blockers are the drugs of choice. So we have a lot of cardioselective beta blockers today, and I think they could be tailor-made and given as per the clinical scenario, individualized as well. Certain situations where sometimes with added on diabetes in present, and sometimes as Dr. Siddharth Shah and Dr. Mangesh Tiwaskar also mentioned, and ACE inhibitors or ARBs can be brought in. And aldosterone antagonist receptor blockers also have some little role in the treatment of cardiac failure with hypertension. Not to mention also little of hydrolazine at times has been proven to be beneficial.
Okay. Mangesh, what is the best anti-diuretic in diabetes, hypertension?
Yeah, currently the evidence, even though goes towards probably, I would say thiazide-like diuretics, but still, I would say that there can be some role of MRAs, if the thiazide-like diuretics are. But now currently good evidence suggests that thiazide-like diuretics are the fair drugs of choices, and they do not cause too much of dysglycemia.
What about the indapamide?
Yeah, so I mean thiazide-like diuretics and indapamide is a fairly
because
almost
indapamide is also lipid neutral, and especially in elderly patients, indapamide can be given. That is in the cardiac outcome trials, everything indapamide is favorable. So it scores over the other diuretics.
Yes.
Thank you, Mangesh. Sir, Siddharth sir, what are the beta blockers we use in diabetic hypertension?
As has been said by the Indian hypertension guidelines, we try to avoid beta blockers in diabetics, especially when we know that it causes postural hypertension and remodeling is affected. So as far as possible, we avoid beta blockers. But otherwise, newer beta blockers like carvedilol can be used in patients who are diabetics. I must say that we have on our panel the Dr. Manoria, Dr. Amit Saraf, Dr. Sanjay, Maitra, and Dr. Mangesh Tiwaskar. We all understand that beta blockers we should avoid, but if we have to, at the last resort, we can use selective selective beta blockers like carvedilol.
Yeah, if there is a compelling indication when we have to use beta blocker, carvedilol is the best drug in a diabetic hypertension. Thank you, sir. Why the mortality of uncontrolled hypertension is 1.5 to 2 times more compared to normotensive, PC Manoria?
Thankful to you for asking very tricky questions. Now, it's very important to remember that the mortality in a controlled hypertensive is 1.5 times, 2 times compared to a normotensive, which clearly gives the message that you should prevent hypertension and prevent hypertension. And there are a couple of reasons for this. The first reason is atherosclerosis continues unabated even after control of blood pressure. So you can still get a stroke, as we say, you can still get a myocardial infarction, you can get stroke. The second important reason, which is not widely disseminated, is if your hypertension remains uncontrolled, fibrosis develops in various parts of the cardiovascular system. The fibrosis in the myocardium makes the patient more prone for diastolic heart failure, more prone for sudden cardiac death. And this is very easily demonstrable by LGE CMR, late gadolinium enhancement. And this does not apply to the hypertrophic ventricle of hypertensive, but also applies to cardiomyopathies and aortic stenosis. So an intelligent surgeon these days always looks at the CMR before operating. The results will not be good if patient has hypertrophy with fibrosis. Then there occurs fibrosis in the left atrium, makes the patient predisposed to atrial fibrillation, thromboembolic phenomena. It occurs in large vessels, which increases stiffness and makes the patient prone for isolated systolic hypertension. So hypertension should be treated early, and the dicta remains prevention. Prevention must be attempted because even if your blood pressure is controlled, you are still at 1.5 to 12 times risk. So that are some of the reasons.
But one important message in this COVID times, the people with controlled hypertension has got the same equal morbidity and mortality than the uncontrolled hypertension. So the key is, even if you develop COVID, if your hypertension is controlled, your morbidity and mortality is as equal as normal. Now, Amit, our Sanjay, what is the secondary hypertension? Why people come to nephrology whenever there is a uncontrolled hypertension, and when there is a secondary cause, why do they come to nephrology, and what do you do? How do you approach?
Secondary hypertension, very simply described, is hypertension due to a disease or a condition or in any other organ. And why they come to nephrologists is because most of these hypertension patients are ones who are young, who have sudden onset and very high blood pressure levels, and to the nephrologist because the kidney, either renal parenchymal or renovascular, is one of the commonest causes of secondary hypertension. Secondary hypertensions are the ones who have to be treated very early, diagnosed and treated, managed very early, because they generally end up causing a lot of target organ damage, including being a kidney specialist, particularly the progression of chronic kidney disease and Others definitely cardiovascular disease, etc., which has already been discussed. So the first thing in any severe hypertension is the risk factors which have been attributed to obesity, sleep apnea, etc., poor control of blood pressure, this LVH, etc., has to be looked at. And once this has been diagnosed, the target has to be achieved quickly. You can start with 2 medicines, 3 medicines. Make sure at the same time that you found out how severe the renal failure is. Is there anything else like a secondary, a hyperaldosteronism or a pheochromocytoma, a thyroid problem? These are some of the very common things. Once you've ruled it out, if there are no significant things, then the first motive should be to control the blood pressure, not worrying how many blood pressure medicines you are using. Maybe generally you need 2 or 3 medicines, including a diuretic, and mostly in terms of mineralocorticoids.
Thank you. Thank you, Sanjay. Dr. Amit, do you use statin for all hypertensive patients? If so, what is the ration behind it?
So right in the beginning, before even the atherosclerosis sets in, there is a phenomenon known as arteriosclerosis. That is a stiffening of the blood vessels. So there is definitely a role of first lifestyle changes. Statins come into play a little after if the patient doesn't adhere to lifestyle changes, dietary modifications. If the atherosclerosis is already set in, then you're worried about the secondary problems of maybe a plaque fissuring, a platelet plug formation, ultimately an ischemic event. So somewhere for plaque stabilization and atherosclerosis also removal, you need statin therapy to be instituted in a hypertensive a little early on. Choices are varied. We have statins, we have nitrates, we have fibrates, we have nicotinic acid as well. People have tried fish oil to a certain extent in the treatment of lipid therapy as well. So I believe, but the standard statins for their pleiotropic effects are very commonly seen, and a low dose statin can be continued in, I would not say almost all hypertensives, in those hypertensives which a family history with risk factors like smoking, like with ischemic heart disease, with other risk factors, they should be added early on in the treatment.
Manoria, you can add a comment on what Amit said.
We have 2 trials which is an eye-opener to these patients. Firstly, we have data from the ASCOT-LLA trial, which showed that if you add nearly 10 milligram of atorvastatin, there's a 36% reduction in MI and fatal CHD deaths. So that was the first trial which initiated this issue. The second is the HOPE-3 trial, which showed that if you use only candesartan plus hydrochlorothiazide, there's no change in the incidence of cardiovascular death, MI, and stroke in patients who are at intermediate risk without any cardiovascular disease. But if you had 10 milligram rosuvastatin, there's a 24% reduction in the incidence of cardiovascular death and MI. And what appears to me is very striking that when we examine patients, when we examine specimens of coarctation of aorta, most of these kids do not have any risk factor for atherosclerosis, but all of us have seen there's extensive atherosclerosis above the coarct, no atherosclerosis below the coarct, giving a message that hypertension damages the endothelium and perhaps allow macrophages to enter the subendothelial tissue and initiate atherosclerosis. So that may be one of the reasons, but hypertensive patient, even without risk factors, can have atherosclerosis. But we don't have any large trial on this, but these are the 2 data from the trials which show that even if your patient is intermediate risk, your risk of cardiovascular event is less than 1% per year, you can still be benefited from statins, low dose even.
In fact, the Lipid Association of India has come out with a guideline. If you have a CBS score for lifetime risk, for all hypertensives, it is more than 30%. So if there is more than 30%, they come into moderate risk category and they can be given statin. That is their recommendation. And of course, HOPE-3, they have done only the intermediate risk, and then they found out this statin is better than the antihypertensive in reducing the cardiac events. Thank you, sir. Mangesh, does diltiazem have a role in management of hypertensive CKD after optimal uses of ACE and ARB?
Diltiazem?
Yeah.
Sir, as far as non-DHPs are concerned, as far as management of hypertension concerned, I'm not very sure about their role.
Sanjay,
Yeah,
Sanjay, you can answer.
Yeah, that is what I was to come to that.
Sanjay,
please ask Dr. Sanjay on that.
Definitely, non-dihydropyridine, this calcium channel blockers have a role in the management of CKD patients with hypertension. if there is significant proteinuria and the blood pressure levels are not achieved even after starting ACE inhibitors or ARBs. The reason why it is said is that the ordinary calcium channel blockers, like the dihydropyridine calcium channel blockers, cause afferent arteriolar vasodilatation, and there is some data to show that they increase the progression of CKD. In this context, definitely non-dihydropyridine, like for example diltiazem, we use very commonly, and I have found that it is a good add-on to the ACE inhibitors and ARBs because they are reasonably effective, not as effective as the other ones, but definitely in terms it can reduce the proteinuria. Now, coming to the question whether you can use a cilidipine or a benedipine, well,
Yes, that was what.
went in different.
Yeah, in fact, I was to ask you the same question, sir, that,
Yes. Now in
where you
today's-
have got more renal specific calcium channel
Yes.
blockers on board.
But
How
if
much
you
the
really
role of
look at
non-DHPs?
guidelines, if you really look at the guidelines, the KDIGO's controversies conference and all, as late as 2017, they have mentioned this very, very clearly. Now, in today's context, L, N, and the T channel blockers, there's a bit of a thing, and many of us do write cilidipine and benedipine more as compared to
Yes,
this
exactly.
group of medicines.
Yeah, but cilindapine is a good drug, but as the anti-hypertensive effect,
It
it is
is.
not as good as amlodipine.
Absolutely.
So it is a weak anti-hypertensive. Of course,
Absolutely.
benedipine has got 3 channel blockers, and so we are preferring benedipine. Of course, it's a Japan drug. We are trying that also. Thank you, Sanjay.
Yes.
Sir, Siddharth sir, you have mentioned an importance of diet in the guidelines. So throw some more light on diet, because this is a field where everybody ignores. Even the doctors, we advise, but we don't follow. Kindly throw some more light on diet and hypertension.
Thank you for asking me this very important question, which should have been the first question, I believe. As far as the treatment of hypertension, lifestyle modification comes first and last. Because if a patient stops his lifestyle modification, like diet, then his blood pressure, whatever the drugs may have been given, will become ineffective and the patient's blood pressure will rise. As far as the diet is concerned, what is important is to restrict the salt in the diet of the individual. The things that are to be avoided are pickles, papads, and pastries, as it is commonly known that these things should be avoided. 4 grams of salt is allowed to the hypertensive patients on a day-to-day basis. Important thing to understand in our country, in our guidelines also, is that we have different different parts of the country, different temperatures, and where it is extreme heat, person can lose a lot of water and salt. So you have to be very careful how much salt has to be restricted in this type of patients, because this can create a lot of imbalance. Also, you must try to do regularly electrolytes to find out if these patients have hyponatremia due to the diet itself or due to the drugs that the patient is consuming. And hence, what is important is that diet has to be individualized. Patients has to be educated regarding the salt intake, avoidance of certain drugs, especially in chronic kidney disease. One has to avoid the fruits, and in patients who have proteinurias with hypertension, one has to avoid high protein diet. This is what basics of diet in a hypertensive patients need.
Thank you, sir, for bringing out that important, useful, practical data. Dr. Manoria, sir, what is early vascular aging and what is the relationship with hypertension and early vascular aging? How do you diagnose early vascular aging?
Hypertension is a very important cause of premature vascular aging. These days, we can determine prevascular aging non-invasively by measuring the brachial artery blood pressure, systolic and diastolic, by the central aortic pressure, the pulse wave velocity, and the computer calculates you for vascular aging. So you have three subset of patients. One, the vascular age is same as the chronological age. Second, the vascular age is higher than the chronological age. Another, rarely the vascular age may be lower than the chronological age. And hypertension is a very important cause of premature vascular aging, because if the vascular age, you are prematurely getting the vascular age, you are more prone for cardiovascular events. So hypertension is an important, and this is how they give the numbers also. 50 years old age is vascular age is 60, or 55 years old is vascular age is 50. So you can even get the numbers, and that creates an alarm to the patient, and the adherence of the patient to therapy increases. So that is one of the way even to get a number of the vascular age in a given individual.
What about central aortic pressure? Is it useful to find out the early vascular aging?
Yes, when we calculate the vascular aging, they also calculate the central aortic pressure, and all these calculations, the central aortic pressure also comes into weight. Okay. Central vascular aging, as we know, is a better predictor of cardiovascular events, and obviously for the vascular aging.
Thank
How
you,
about carotid intima media thickness, CIMT?
That there's a lot of controversy. People don't this. Central aortic pressure is, and as ambulatory blood pressure has come in vogue, I think after 5-10 years, this will also come to our clinics.
Okay, Sanjay, I ask a simple question. What is the earliest change in BP when you see a CKD patient?
Well, in that case, on the clinic blood pressure, routine clinic blood pressure, even though it may not detect, the ambulatory blood pressure may see a change in the nocturnal dip. That's the reversal of the nocturnal dip, or an early nocturnal hypertension. That's the earliest change. And it is seldom detected in the clinic context. And there are multiple problems, but just to emphasize, the blood pressure as of today, we should be, if there are no major comorbidities, the target is 130/80, and better still, 125/75 in the view of the SPRINT trial and the latest data. There is controversy in this and has been mentioned, but this is what I would take. But to answer this, it's ABPM.
Yeah, Mangesh,
Yes.
do you advise ABPM for all patients of hypertension, or a certain sector of people?
The places where we probably advise ABPM, ABPM is not for all. And as Dr. Sanjay has already pointed out, and even Amit and Sir, Dr. Siddharth sir has also told, that, in a patients, those who have probably, you're suspecting mass hypertension, or people, those who have got white coat effect, or, you want to find out about the why the therapy is failing, or sometimes you need to find out even the drug effect. These are the patients whom you may probably advise 24 hours ambulatory blood pressure monitoring. And as Dr. Sanjay has already spoken very well, that it could be the absence or the reverse nocturnal dip pain, which could be one of the earliest indicator of the development of a CKD. These are the things where you may ask for, but ideally not for all. Somebody presents to you with a blood pressure of 160 or 120, you don't require an ambulatory blood pressure monitor. So
And
whenever
even-
you are suspecting mass hypertension or the white coat effect, these are the people.
Even for the drug,
Yes, and drug
scheduling,
effect or drug
that-
failure, you want to judge the
Yeah,
drug
you have to do
therapeutic
all this,
effects and all that.
Amit.
These are the areas where you can
You
ask
have
for
to-
ambulatory blood pressure monitor.
Okay. Sir, Siddharth sir, do you give combination therapy in the first day itself, or how do you approach hypertensive patient?
A very important point you have brought out. Now, all the guidelines have said that combination therapy early on is recommended in management of hypertension, because single drug is not able to do the performance of bringing down the blood pressure to a target level. So combination therapy at an early stage is recommended in patients having very high blood pressure on seeing on the first visit, having 180/110 and higher, or grade 3 type of blood pressure. I think combination therapy can be initiated in this type of patients.
Thank you, sir. Thank you, sir. PC Manoria, sir, what is isolated systolic hypertension in young? Is it common, and what is the drug you give for isolated systolic hypertension in young people?
I think these days we are seeing isolated systolic hypertension in the young. We have a lot of young individuals from the IT and other sectors who are very anxious, very tense. And when we give small doses of beta blockers, the blood pressure is controlled and they have a good feeling of well-being. The long-term impact and the long-term trials of isolated systolic hypertension are yet to be conducted, but this is one of the observations that in this subset of patients, particularly in Indians who are hypersympathetic, beta blockers produce good response.
Okay.
So Muruganathan sir,
yes.
next 3 minutes, is it possible to close, sir?
Oh God. Okay.
We are running late.
Okay.
Thank you, sir.
I can finish it 3 minutes. Now, before I finish, because the panelists are very experienced persons, so give me
Yes,
2 more minutes. 5 minutes I take. Okay.
Yes.
Now, Mangesh, some of the complicated comorbidities like psoriasis. Any precaution in a psoriatic patient with hypertension?
Yeah, certain drugs to be avoided. Sometimes there is a possibility of high incidence of probably psoriatic exacerbations with certain drugs. There, probably you need to be a little careful when you are using ACE and ARBs. You need to be a little careful.
In fact, Mangesh, why I asked this question, you should avoid beta blocker because
yes, and that's what I was coming to my second. Yes,
so
my second answer was that you should be careful because ACE and ARBs and beta blockers are the two drugs where you should be very careful.
Very careful.
And preferably the drugs of choice there. You should be using mostly the calcium channel blockers would be the first choice of therapy when it comes to psoriasis.
And Sanjay, in a case of HIV with hypertension, any particular drug you should avoid?
Well, HIV, the problem is firstly hypertension, and I'm talking only of HIV nephropathy. I'm a nephrologist.
Okay.
In general is all right, but HIV associated nephropathy, where it's very uncommon to find severe hypertension in this group. Now, coming to your question, I would be a little hesitant unless I know the therapy, because many of the HIV drugs are itself nephrotoxic, and without knowing, and particularly if the blood pressure is not very high, I would be a little hesitant to start ACE inhibitors or ARBs if the patient is not under my regular follow-up. If the patient is under my regular follow-up, I will monitor them strictly and continue the usual panel.
Because most of the retroviral drugs, protease inhibitors, act with the CCB, for example, it may increase the concentration of CCB,
yes,
or it may decrease the efficiency of losartan. And in a case of hyperuricemia, when a patient with hypertension, it is an ideal drug is losartan, because you should not give diuretics, yes, it may cause gout.
Yes.
So whenever there is a comorbid condition, when you do a drug trial, when you do give drugs for other diseases, you should be very careful. Same way in a rheumatology patient where they have got osteoarthritis, you should avoid NSAID, because if the NSAID is there, hypertension will increase. And when there is NSAID, you should always give calcium channel blocker is the ideal drug for people. And people who are smoking also, the ideal drug is calcium channel blocker. That's why, the drugs very important. PC Manoria, we cannot leave without talking about one comorbid condition is COVID and hypertension. Just 1 minute, your message, and then we'll wind up.
COVID, hypertension does not predispose to COVID. Uncontrolled hypertension, getting a COVID, the mortality is increased. COVID does not facilitate entry of the virus into the cells, and RAS blockers should not be withdrawn. In fact, they were found to be decreasing morbidity and mortality of COVID.
Okay, so
they are not contraindicated, should be utilized.
Thank you, PC Manoria, because we had a very long discussion. Previous speakers spoke about COVID and hypertension, so I thought I will summarize that. And then the topic given to me is prevention. So we have not talked anything about prevention. So you can prevent hypertension, people developing diabetes by targeting nocturnal blood pressure. There is a study. If you control the hypertension, they may not develop diabetes for 5 years at least. Same way, a patient with asthma or COPD, if you give proper treatment, bronchodilators, if they don't go for hypoxia, they won't develop hypertension. Same way, if the patient with rheumatoid arthritis or SLE, if you give hydralazine-like drugs, that may produce hypertension. So whenever there is a comorbidity, you can prevent hypertension from the comorbidity. Also from the hypertension, you can prevent comorbidity. So both the ways we can prevent. So prevention is the title. So that point for food for thought for all of us, that comorbid condition, whenever they get, how to control hypertension. When hypertension is there, how to control comorbidity. Now, the final message and words of wisdom from Siddharth Shah sir, and we'll wind up. Siddharth Shah, a drive home message for all the audience about the whole hypertension control.
I think, Dr. Muruganathan, we have discussed almost all the aspects of hypertension under your guide, under your leadership. And I think that what is important is education and follow-up of these patients. It is very, very important to control the blood pressure.
Yeah, thank you, sir. And my message to all of you is focus on hypertension, because we have got so many diabetologists, but we don't have hypertensionologists or hypertensionists. First, finally, get a validated BP monitor and have 3 cup sizes. You know, always in every clinic we have only 1 cup. We don't have obese cup or a small lean cup. So buy a 3 cup. You have a validated BP monitor. Focus on hypertension. I would like to develop more hypertensionists and hypertension clinics under the leadership of Siddharth Shah. So that will be a very good message, because we have got more morbidity and mortality and incidence of hypertension than the diabetes. With this, I conclude. I thank the organizers at Professor Siddharth Shah, Dr. Srish, Dr. Manjula, and all the panelists for their excellent deliberation and discussion. Manoria, Amit, Saraf, Sanjay, Mangesh, and Siddharth Shah, sir. Thank you. Namaste.